active agenda today. With the smaller group, we may not utilize the full schedule, but we do want to have that available if that is something that we need to utilize. I'd rather have a little extra time than not enough time. So we're just glad you're all here, and would hope that we can fill some of the time, get some updates from SAMHSA, and also hear from all of you about how you're doing, and as we get ready to sort of transition and make some changes with the TOR program. So I know we're gathered here virtually, but we want to take a few moments to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a few moments to read this land acknowledgement, which was created by 3 members of our team, Ellen Keeley Driscoll and Mr. Sean Bear. Thank you. I know oftentimes following our events, we do provide links to any slides that are associated with that presentation, and the events are typically recorded and made available at a later date on our Native Center for Behavioral Health YouTube archive. I don't believe we are offering any CEUs for these events. And lastly, we will ask for your participation to complete a short survey. The survey is completely confidential. It cannot be linked to you in any way. We value your feedback and would appreciate a few moments of your time to complete this short survey. You can skip any questions you would like. But we would really love to hear back from you. We'll make this link available in the chat again before the conclusion of today's event, and then again we'll reach out to you. I believe we're reaching out to folks post-event. Meg, are we doing that for the TOR events as well?
Yes.
Okay. Yeah. So there'll be a follow-up email, and you'll have another opportunity to complete that short survey. So we'd love to hear from you, and we certainly value any feedback you could offer. Thank you.
Thank you, Steve.
Of course.
I think now we do not have a grantee presentation today.
I'm doing an editor.
Oh, good. Okay, thanks.
There we go.
Sorry about that. We do not have a grantee presentation today. This week seems to be very busy for presentations and conferences and things. But we do have Brittany here to provide some updates on the TOR program. And take it away, Brittany. You should be able to share your screen if you like.
Okay, yes,
just remind everyone too, before Brittany gets started, to make sure that you are muted, just out of respect for the presenters. Christine, I think there seems to be an open mic off and on with you. Meg, if you could just co-host me so I can kind of help monitor that, make sure we keep everyone muted unless you're called upon or you have some interesting comments. So sorry, Brittany, to interrupt, but.
Oh, no worries. Thank you. Much appreciated. I'm going to share my screen in just a second about SAMHSA TOR GPO updates, and then I'll just leave room for a couple questions if anyone has any questions on what I'll present just some few minor updates, not too much. Let's see. Can you all see my screen in full view mode? Okay, just checking. Sometimes it doesn't necessarily work that way.
You
Okay.
might just try swapping your display settings, Brittany. So otherwise, because we're seeing your notes section there. If you just
yeah.
do swap display, it'll.
1 second. Let me stop the sharing part. Should be just in PowerPoint mode.
So Brittany, if you go ahead and start your slideshow from the beginning,
Yeah, 1 second. It should
and
be.
then at the top, display settings.
Click on display settings and just put
No,
swap view.
over.
Oh,
Hold on 1 second, technical difficulties.
go back to where you were, and up on the bar up top, there will be a display setting. You can just switch that. I only know this because I learned through trial and error, and I learned
Yeah,
that well to use my display settings switch.
I've had to do that multiple times.
Yeah.
Okay, I think I got it this time. So let's see if that worked out.
My fingers are crossed. Yeah,
Okay,
if you
now
just-
up in display settings.
It went back,
Yeah.
it reversed
Yeah,
back.
that's
Yeah.
okay. Just there you go.
Swap.
That's
There you
it.
go.
Okay, sorry, it's reversed back, but
We
okay.
got it. We
We're
got
here
it.
now. Well, I'm Brittany Barbara Alexander. I'm pretty sure everyone on this call probably knows who I am, but if not, I'm one of the TOR GPOs here, also public health advisors on the TOR team. Like you guys previously stated, Will Longinetti is out this week. He's moving. Paul is actually on site visits currently in Alaska, visiting his grantees in Alaska. And then some of my grantees are actually on this call because I cover a part of Alaska, mostly the other regions in the southeast side. So I have some grantees in Alaska, New York, Florida, most of the East Coast for me. So I just want to give an update about some of the things for TOR right now. TOR closeouts. For anybody who has a TOR 2019 grant right now, all the grants in on the 29th of this month, which is next week, next Thursday. So grantees who will not be doing no cost extensions or did not already submit for no cost extension must submit these things that are needed here, which is at the bottom. The final financial report, the final progress report, and the final tangible property report, those things are due in ERA in the PMS system, which is the payment management system, by the end of this year. So please turn those in as soon as you can. We do recommend that you turn it in as soon as possible. So that way, if you are going for the next grant, that you can complete one grant and begin with the other. So that way you don't have double set of documentations due or multiple things due in ERA or the PMS system, just to keep some separation there. Makes it easier. As far as the GIPRA data situation goes, nothing really much has changed right now. Since I think the last time we discussed this on April 1st, 2022, that's when the new GIPRA data tool went into effect. All grantees should be entering their Q4 data collection information by the end of next month, which is the 31st of October. This replaces the 3-question naloxone tool. And then we have plenty of training videos on the SPARS website, so feel free to click on this, and all slides will be sent out after this meeting. Updated instrument for collections for overdose reversals, fentanyl testing strips, and education on school-age children, first responders, and key community sectors on opioid and stimulant misuse and outreach activities that have been targeted underserved and diverse populations. This is all stuff that's already been in effect. Please make sure that you're collecting your GIPRA data if you are providing medicated assisted treatment and you're using your grant funding. This again just talks more about GIPRA, which you should probably be fully familiar with at this point. What we really care most about is that you are doing your intakes. That means any client that is receiving, again, medicated assisted treatment through TOR funding, that you are doing intakes with each client that's being serviced. We do care about 6-month follow-ups. However, I know that that might be hard to complete because some people do not remain in treatment for 6 months or stay with you all or may move on to other services, but do as best as you can. Do try to complete a 6-month follow-up if you can. And then definitely if you have someone that's staying with you past that time for discharge, we do ask that you complete that. This helps with your TOR funding. You guys are funded with TOR based on how many of these we receive, because what we want to know is how much of the TOR funding is being used for medicated assistant treatment. So please, again, keep entering your GIPR data. And I do know that we are still, again, trying to shorten the GIPR data collection tool. I know it's very long and tedious, but we are making ways to shorten it so you can ask less questions to your clients you're servicing. Which brings me to this next slide. The revised GIPR client level 2 will go into effect on January 1st, 2023. I know that specifically for the TOR team, I know we've, I think, eliminated at least 3 of the GIPR data slide questionnaires. I think it was 3 pages out of the 26 pages that are there. We've eliminated 3. Yes, I know we want to eliminate more, but I don't know what's the final GIPR data rollout until January. They'll let us know, but emails will be sent, and they were sent out on 6/23 explaining these changes. So please refer back to that. If you have questions, please check out the GIPR2 at samhsa.hhs.gov for any detailed questions about that. They should be able to help you with that. But again, our goal has been to shorten it because I know it's very tedious and long to answer some of the questions. Also, as a clinician, we don't want to traumatize anybody by asking questions that are unnecessary or not really needed to be answered for the grant. So we definitely eliminated some of the questions we deemed to have been not really necessary, such as someone's drug use history, dealing with the court system. If someone has any charges like felonies or things like that, we've kind of eliminated some of those questions. So that's just one thing to note. Again, if you need anything dealing with the SPARS system, please contact this 1-800 number here or contact the SPARS help desk. I know that if you do not log into your SPARS account within 30 days, they will log you out. So you will have to resubmit to get a new password. I've been locked out personally, so please make sure you stay up to date in the SPARS system. These were just recent TOR webinars that we've had in the past, the peer recovery harm reduction. That was on August 24th, July 27th. We had the contingency management seminar. June 29th, we had support staff and addressing compassion fatigue. These are just some of the previous recordings that we have that are still online. Again, after this meeting, you can click on each one of these links and it sends you right to the presentation that were recorded, if anybody missed one of them. And you should be still having monthly or bi-monthly calls, at least with your GPO, your grant project officer. Myself, Will, and Paul, we like to meet with you again to discuss your grant spending activities to make sure that you're staying in line with what you stated you would do with your grant. Also, if you're having any issues with your spending down funds, or want to kind of pivot what you're going to spend funds on, maybe you might need to do a budget revision or things of that sort, please reach out to us. If you haven't been in touch with us, or if you're having any difficulties, just let us know. Also, again, keep doing your GIPR collections and definitely keep checking ERA for your deadlines for when your progress reports, mid-year reports, and the year reports that are due. And this is the way that you can contact each one of us. My name's here, Paul and Will. We cover for each other. So if one person's out, then we cover. Paul and Will are both out this week, so I'm covering for everyone. So if there's any urgent things that need to be answered, please reach out to me. Anything else that I can't answer, I work with your grants management specialist, who's the budget person, to answer your questions, or wait for Will and Paul to get back next week and they can answer any detailed questions about your specific grant that I might not be able to answer if I'm not your GPO. I think that's all I got for you today as far as that goes. The only other thing I would say, if you applied for the new TOR 2022 grant, that should be, notice of award should be being sent out soon, between now and the end of next week. And if you also applied for a no cost extension, if you have a TOR 2019 grant and you're extending past next week, those notice of award should also be sent out. We're a little backlogged. We've had a lot going on this month. And also we extended some deadlines for folks who applied to the TOR grant. I think there were 110 applicants. for this 2022 notice of award funding period. And I think we're awarding 103. I can't give exact dates and times, but it should be between now and the end of next week. And as far as no cost extensions, I think there are about 15 grantees who applied for no cost extensions. And those should be awarded again next week as well. If you have any concerns that something's not right or haven't heard from anyone, please reach out to your GPO and your GMS. We've all reviewed them. They're giving out the final awards for that. So the GMS will award you that. So I guess I just want to open up to any questions that you may have for me, if I can help answer anything that I didn't.
Oh,
Ms. Ikeda.
uh,
I'm good.
Okay, something happened there. But yes, if there are any questions for me as a GPO or any TOR related questions that I can help answer, hopefully I gave you some updates, because I know everyone's probably wondering when we're getting funded for the next cycle. That's the answer I have at this time. Any questions? You can also write in the chat if you feel like doing that as well. Hold on, I see. Oops, someone's having a good time. I want to laugh too. Let's just see, did I read in the chat? Nope, there's no announcements to that, Meg. I see your direct question. We have no insight on that as well. I think everything is delayed, so I'm guessing based on what I just said for the grants and TA providers, all of that answers will be given by the end of this week or next week. We don't get updates on that either.
Okay, thank you for clarifying that. I'm sure everyone here is aware, but as a reminder, the National AIAM-ATTC will no longer be providing TOR, TA, or trainings after next Thursday. And we have been waiting for SAMHSA to announce who the new provider would be. However, we will have one more webinar next Wednesday, and I will put the registration link in the chat for everybody. And I hope you're able to join us, because we are going to use this opportunity to share some tools and resources as a thank you for allowing us to be part of your journey and experience over the past 4 years. We also are expanding the Care and Share. This has been a really very popular program among the core grantees, and there are some other providers who have expressed interest in participating in that kind of forum. So we will be starting in November, we will continue the Care and Share, but it won't be specifically for TOR. It will be for prevention, treatment, and recovery professionals serving Native populations of communities. And all of you are welcome to attend those as well. Beginning in November, it'll be the second Wednesday of the month, as it has been. October, we had to reschedule a little bit. So that one will actually be on October 26th, and I'm putting the registration link for that in the chat as well. Doug asked about the new GIPR reporting tool. And Brittany answered, yes, it will be on the SPARS website when it is live January 1st, 23. The current one is still up now on the SPARS website. I thought.
Actually, I take that back. I misspoke, because I'm looking at it right now. They have an updated one up there right now. And if you go on the SPARS website under announcements, it's actually up there right now. But the newest one, when they change it, will be up as well if they make any additional changes. But this one is from 12/10/2022. That's the one that's current.
Yeah, and they, because we had gotten a notice that the raw data would take a while to switch over. So I think they did that one last month or earlier this month, Steve. Was that when we got that notice?
I think you're right, Meg.
Okay, I do have, the, responses from the registration report. And about topics that you all were interested in, today. But before we go into that, Steve had, a resource to share. Something that is specific to Iowa, but, Steve, you take it.
Yeah, I just wanted to, and I know there may be those of you in the Alaska area, there may be something comparable. A lot of the attorney generals were tasked with creating sort of reference or repository sites for individuals to seek out treatment or support for OUDs. And our attorney general here in Iowa released this opioid resource site, and I wanted to just give you a quick look at it. Oh yes, thank you, Meg. And I think if we're going to run that little video, we just have to make sure. I was going to share this short video, this promo video. We just have to make sure we share audio on the screen share.
I'll let
Just
you
have to.
do that because it'll be.
Yeah, let's see if I can pull this up. I just wanted to share this with you guys. I'm going to do share sound. And I would be curious too to hear. Can you guys see this okay on my screen now?
Mhm.
Yes. I would just be curious to hear from those of you on the call as well, if your states, particularly Alaska, has something comparable. But I just wanted to give you a quick kind of look through. As some of you know, Iowa has 99 counties, so they broke it up into areas based on distribution of those counties. And then they linked each zone or each area with a specific provider that you can go in. And so it's really finding something local or near to where you are living to try and get some help. And I wanted to just run this video if it'll let me. Can you guys hear that okay?
This can happen to anybody. People shouldn't be punished for it.
We do a lot of stigma busting. Your brain is not functioning as it could or should because of the opioids that are in your system. So I very much take away the blame.
People are at a point in their lives where they're just wanting to make a change and they want to make a positive change.
You know, I try to instill hope. I really believe that everybody deserves that kind of compassion with treatment, and this is a treatable condition. I think there's several reasons why we have this misconception that it's not treatable. One is because of stigma, and because if we say that people develop an addiction because they're a bad person or they made bad choices, then we're not thinking about it as a treatable condition.
If you only worked harder, if you only had a little bit more motivation, you could get through this.
As a society, we've all just sort of absorbed this idea that it's not a medical problem and it's not treatable.
Our medications work really, really well, and we need to really start to dismantle a lot of barriers that are keeping people from accessing them. Sometimes people have never heard of our medicines before.
MAT stands for Medications for Addiction Treatment, and treatment is very effective and it's pretty rapid. It also prevents withdrawal symptoms, and they don't have to worry about having cravings.
Maybe I stay on medications for 5, 10, 15 years. It's kind of like a daily medicine that I take for my blood pressure, my diabetes. It's just something that I take to keep me well.
I've certainly seen a lot of people who they felt like they had lost control of their opioid use, and then they start treatment and they feel a lot better and they feel like they've gained control over their life again.
What kind of invigorates me is just to watch them be able to get relief from so much suffering.
We've got great team members of counselors and masters of social work and case managers that help put together the rest of their life as well.
I have so many patients that that have just amazing inspirational stories and have come so far in their recovery.
A lot of people who seek our treatments might still struggle, and they might still have slips, and they might still, take a step backwards, but hopefully still, taking those 4 steps forwards.
The medical model is very beneficial to these patients. They can get better. They can be back to having a full life with their jobs. They can have a full life with their family. They can be in a much better, safer, healthier place.
Just that self-confidence and that sense of empowerment, it helps them build some of those skills for being successful with their next goal.
Thank you for that shameless plug for University of Iowa Hospitals and Clinics.
Yes, well, I didn't realize that it was connected directly to the university, but yeah, I'll score some points somewhere with that. Brittany, just forgive me. I didn't realize that we had University of Iowa connected to that, but I think I just wanted to share this and maybe more so generate some discussion and hear from other participants on the call today. If Alaska's got something comparable to this, or a mechanism where potential patient or family members can go, and there's several other links here, but I thought it was a nice effort. It's certainly it's one thing to have access to the resources, but there are a lot of other moving parts connected to beginning the recovery process, particularly from someone with issues related to the opioid use disorders. But I wanted to share this and just open the floor, maybe if anybody has any comments, or I saw this link too. I'm not sure what happens if okay, there's Dr. Lynch. There's just some Q&As here, or FAQs.
Steve, can I share a page from the Great Plains Tribal?
Yes, let me stop this here. There we go.
This is similar. They have put together under their behavioral health section a list of private treatment services.
Oh yeah, with the Great Plains, yeah.
And there's actually a whole booklet that people can download that has a map, it has the contact information and everything. And I can put this link in the chat if people are interested in.
Please do. I'd like to look through that as well. And I would put the question out there too to those on the call, if Alaska's got something comparable, or perhaps if you're calling in from somewhere or on the call from other than Alaska, maybe Dr. Garcia could have maybe she has something she could share with us about what Montana's doing. But yeah, thanks for letting me share that, and I appreciate the link to that Great Plains resource as well. The Great Plains Behavioral Health Directors Group. It's a really robust group of Native professionals that have really, really good contacts and resources there in the Great Plains area.
I don't have anything. We are, the Crow tribe has applied for no cost extension, so we haven't officially kicked off our TOR programming, and we will be doing that on October 1st. And I really like the resources that were shared here. They're really amazing. To my knowledge, I don't know that there's anything exactly like that here, but it would be great. The Great Plains resource guide, I took a notes here on that. I'd like to take another look at that. Yeah, this grant was obtained before I became the director, and the director left the program, and it was sort of lying dormant. And so I've assumed directorship of it when it's ready to kick off very soon here on October 1st. So I've been enjoying everybody sharing what they're doing in their communities and these resources that are accessible. But yeah, it gave me a great idea, the first one of that short little video clip, because I don't know that anyone in their community, well, here in Montana or whoever is on, has done some sort of a commercial like that about opioid use and places they can turn to. Is there someone on here that's done something similar?
Yeah, I'm involved in a lot of like state work and with the Alaska Native Tribal Health Consortium. And so OSMAP really hasn't, OSMAP, Office of Substance Misuse and Prevention, is the ones that it runs Project Hope. So they, that's where a lot of us get our Narcan from. They have a whole website. They have a bed availability checker, videos. There's a lot of commercials. There's a lot of stuff being published in the Anchorage Daily News right now. Currently, the state of Alaska is looking for public comments for the state opiate remediation plan. And I can put the link in there for public comments as well. And then there's the Alaska Native Tribal Health Consortium has an addiction medicine echo that people are absolutely, and we're always looking for case presentations for echo. There are a lot of us use the CDC videos done that were the Alaska Native and American Indians. There's CDC videos that were done by residents of Alaska who actually work in treatment or trying to at this point. So there is a lot of stuff just kind of spread out, but we're all working together to be cohesive. The Alaska Native Tribal Health Consortium's currently got a pilot project for getting HoloLenses out. So you guys can contact Tim Collins at ANTHC for that. I'll put the link, Steve, for the CDC videos.
Thank you.
Yeah.
I'd like to know if you all think that videos that was native specific, like the one that Steve showed us, would be helpful in addressing the stigma around people with addiction, and also the resistance to harm reduction measures.
I really think that would be awesome. I would like to see some videos like that made in this area where I'm at. That's why I was asking if anyone out there has done anything similar along the lines of that, because that was a very excellent video.
It really was, and I really liked the fact that that it talked specifically about stigma and the fact that it is a medical issue and it is treatable. That's, I think that if you stop 10 people on the street and ask them what they thought about substance use disorders, that they would say it is not treatable. So I think it's really useful from a public education standpoint.
They are the hardest to treat. I've been a substance abuse counselor for 20 years, and I've worked in treatment programs where we had patients with opioid use disorder, and of all of the patients I've had to work with, they are the most difficult, but I haven't worked with any recently that are on medication assisted treatment. So I'm really interested to see how effective that would be here where we're at. So that is a part of our grant, is being able to coordinate a MAT program for the Crow Tribe.
In Alaska, there are 3 providers who do have the IHS designated waiver, so they can provide telemed services and help with buprenorphine inductions. What we see here in my experience has been agency policies that are not conducive to people seeking medication for addiction services. So and it doesn't come from the medical providers. It's like the agency itself, because addiction medicine patients they're like my favorite people to treat. And I'm not a doctor. I do a lot of outreach and education and stuff, but we currently work with like three tribal entities that don't provide MAT. And so we actually have to fly patients to our community because patients can't access services in their home community. And so, but there is the IHS designated waiver that you can get where you can provide telemed services to anybody who's in the IHS health system in your state. And I don't think it's just paperwork that you fill out, but that would be a way to help the state through the IHS, and then your clinic gets the payment. So that's really nice, because you can, patients are doing telemed from their homes right now. We don't ask them to go to the clinic or anything, but.
Oh, okay.
And in Alaska, where so many of the communities are remote, and access travel is difficult, that telemed option is really, really important to reaching people where they are. Is that correct?
Utilizing telemed is difficult?
No, it's important. It's
Oh,
important
yeah.
because of the geographical challenges.
Yeah, they can be. We get patients who get stuck on a weather hold and stuff like that. Yeah. One of the things that we're dealing with, and somebody on here brought it to my attention, I believe, was pharmacies not mailing out and pharmacies not taking new patients, which is not true. That's a violation. Don't forget the ADA violations, the American Disability Act. Those things are in play too. So pharmacies are currently denying patients access to medications because of whatever. They're not taking new patients, but there's a few mail-based pharmacies, not just our AHS clinic, we can use for Medicaid. I think there's like 4 maybe that do mail medications, but the pharmacies are not taking new patients right now. So that's currently a barrier that we're running into. But a lot of clinics in Alaska are currently using the long-acting injectable buprenorphine, with having great success for that, which has been a big initiative up here. And then you use your case managers, your outreach workers, your peer supports to just follow the patient week by week, which has been a great way for us to use our TOR funds. But there's a lot of low threshold MAT providers. I don't know any MAT provider within the IHS health system that will not treat a patient if they are actively using substances. We know that it's more important to continue treating them. And so we just changed their formulary. But harm reduction and low threshold care are very much alive and well in Alaska, pretty widely acceptable. We see it a lot more in villages where they don't want people who use drugs in their villages, but there's no services to help people either. So, or that THO, I don't know. So we're dealing with a lot of agency and policy stuff. But from the state level and, working with each clinic locally. And I'm going to put the link in the chat for the state of Alaska's opiate remediation, where anybody can make public comments. It's due in 3 days, but you can totally make comments and recommendations on what needs to happen with the opiate remediation. And then there's going to be a tribal opiate remediation that's happening as well.
Yeah, I appreciate that, and then I know the distribution of naloxone and access to fentanyl testing kits are also, something that is, it's not always well received, to depending on where you are in or around the country. So that's just been in response to the huge spike in overdoses in the past year, and they don't even have the more recent data yet to determine whether that's continued. But the fentanyl issue seems to be sort of overshadowing a lot of the initial concerns, because remember, this all started, as you know, with an over prescribing of opioid medications to treat pain and post-surgery issues. And once that was regulated more through prescription monitoring programs, then you had folks drug seeking outside of the prescription arenas, and the introduction of fentanyl into a lot of the heroin that was being distributed. So it definitely it's very complex, and I know if you add another cultural component to this and some of the nuances with tribal agencies and accessing services, and that can also be another navigation factor in all of this. But I really appreciate, I've got that site up now, Annette. Is it the one that says loved here, safe here, all are welcome? Is that the second link you put up?
I don't know. I
Is
posted for-
Is it this one? Can you see this one?
Oh, yeah, that's, I know mine. That's ran by the Alaska Native Tribal Health Consortium. You can order
Okay.
safe injection supplies, Narcan training, safe
Yes,
supplies, educational material, all that stuff.
yeah, that's a great resource right there.
But you can order
Yeah.
supplies for your clinic or your agency or for yourself, for your
Yeah.
kids, whatever. You can order them through here.
Thank you for that.
Can you guys hear me now? I'm using a different mic. This is Doug Finney.
Yes.
So I
We
wanted
got-
to, I just wanted to echo Annette's comments and add to it a little bit. So we ran into a lot of problems getting our medications mailed out to our clients, because my clients are all out in the Aleutian chain. So there are no pharmacies out there. You have to have a pharmacy that's willing to mail to them. We were able to switch to a new pharmacy here in Anchorage that's actually expanding and setting up their own distribution point for injectable buprenorphine. And so we're really looking forward to that and working with them. So we've got a new relationship with them, and they're serving our clients and getting service to them. But I wanted to address Avis and one of your comments earlier. So I've been working with intensive outpatient program where we have a 12-week program where we counsel people in substance abuse, and those that join our program that are also in a MAP program have been very successful and just doing their and being able to get off substances and carry on a normal life. So, I just wanted to encourage you to, if you've been working with people that are just in an abstinence only program and they're doing an intensive outpatient, trying to, for whatever reason, either the court ordered or if they're there on their own, the folks that have joined our program that are also in a MAP program, so they're getting counseling and they're in MAP, have been, extremely successful. So just wanted to add that.
Thank you for sharing that.
Appreciate that, Doug. Nice to know you got your mic working again there. You were crystal clear. Other comments or thoughts? Meg, did you have, I didn't have that agenda in front of me, so I wasn't sure where we were at with things, but wanted to make sure we open the floor and hear from some of the other grantees and folks on the call.
We have nothing left on the agenda except closing, so.
I'll say something. As a GPO and just as someone that's been learning a lot more about different tribes and how they operate, recently we've been allowed to finally do a few site visits. And I've recently gotten back from 2 site visits, one being last week from Tulsa, Oklahoma and Oklahoma City with the Choctaw Nation. And then previously, the weeks prior to that, I was with the Mashpee tribe on Cape Cod and Martha's Vineyard. What I noticed from going to those site visits, obviously I've been hearing everything they've been saying this whole time that I've been servicing their grants, along with you all too, which are probably really similar. Sometimes it is their tribal councils who are pretty rigid, might be against some of harm reduction activities. That's what I've noticed from like being boots on the ground and actually going and visit their programs and see how they're actually using their funds. And what I would say to that, obviously, if we can advocate in any way and be a part of some of your meetings or be invited to a meeting, we're happy to show up to share what we can help with or offer any answers to any questions they may have, along with our regional administrators. I know when I went to visit the Mashpee tribe in Cape Cod, I myself as the GPO for that grant showed up, but also the Regency administrator who knows what's going on in that region and their SOAR grants in that area and other resources. So we made a deal that we would show back up and visit that tribe again, but also love to be invited to meet with their tribal council to see if we could help mend any bridge there or answer any questions they might have or any hesitation they might have not to be willing to do Medicaid assisted treatment, since that tribe does not. They're against it. They're in the mindset of abstinence only and nothing else. So if we can help change that mindset or help people to be a little more open-minded, we're absolutely happy to do so and be an advocate to you. But I do think it definitely takes everybody being a part of the conversation and maybe some mind changing. I think that's what I learned from that experience going up there to see that for myself, and also down to Tulsa, Oklahoma, which some places are still very traditional, really stuck in a different mindset and not as open-minded. Because again, those 2 grants that I'm describing, they both only do prevention measures. That's it. And even the folks that do go to recovery housing is very limited. There's really not much else to go to afterwards. So it's kind of limited options afterwards. But hopefully what I'm saying makes sense. If we can help in any way, and as we're allowed to travel again and have funds to travel and can help, let us know as GPOs. We're absolutely willing to go if we're allowed to. We only want to show it where we're, wants it to be at. But yeah, that's what I learned from my experience this far. Well, I guess I'll throw out the question, have you guys experienced any more resistance than what I'm describing from some tribal councils? Like you might have this great idea how you want to run your TOR program, or maybe in your up and coming TOR grant, but like maybe you ran the idea or business plan by your tribal council and they absolutely said no to it. What was their reasoning? Or what are some of the barriers that you guys might be facing that I might not be aware of if I'm not your GPO?
One of the barriers I've encountered early on here in picking this grant up and getting it back up and running so that it can benefit the community is the Indian Health Services here is like, there's like a disconnect, I know for a fact that they are starting to treat people with medication at Indian Health Services, but they're not referring anybody for treatment we're the tribal treatment program. And I'm planning to set up a meeting, and I have invited the the director of the behavioral health to come to a meeting that we'll be having to speak to her about that program. And then the other was getting Narcan. One of my staff members had contacted them to look into getting Narcan, and we were told that we have to basically come in and you will only get like 2 doses of Narcan, and that's all we would get. And so there's a lot of work to be done with getting them to work with us more closely so that we can address this more effectively as a MAT program that provides treatment services in addition to on an outpatient basis. So that's my barriers I've encountered that I'm planning to work with.
Can I ask a question? Was there a pre-established relationship between your group and the Indian Health Service there prior to you joining? Or was there a relationship at all? Because sometimes I feel like relationship building is like the beginning part, because sometimes there's no relationship at all. So people stay separate in their isolated areas, and that's why there's no referrals.
Yeah, we're working on establishing a relationship. I was meeting with the tribal health director herself regularly, but it's really important that we get their team involved in working with us and not just her. It just seems to me it would be, I'm not understanding why they're doing it, and then we're not having any coordination of services through our program for the actual treatment component. Because I'd heard this guy that got on earlier and talked about that they're having a lot of success with their program, and I'm like, well, we're not getting the referrals from the Indian Health Services program.
Does that have anything to do with payment models, do you suppose? Are they concerned that that they won't receive payment for the services they're providing if they coordinate with you?
You know, that's a really good question. I am not sure. That's something I would need to look further into. It's not with just the opioids, it's with all the treatment issues. I mean, I don't need to be venting on here, but it's just, as a director of a recovery program here, I'm noticing they're contacting us when they want our help to get someone somewhere. So they're attempting to kind of bypass our whole program and trying to get tribal members into treatment, as opposed to working with us to refer them here for outpatient services and whatever services we can offer. So it's something we're working on. It's just in the beginning phases. So I am headed in that direction.
We always offer outpatient services to patients, like it's part of the intake and screening process. Like, is this something? We actually got rid of the language MAT program because our MAT is provided by our primary care providers and no like behavioral health. And the word program kind of insinuates that if you don't do A, B, and C, you don't get D, right? And so for some people like, well, if I don't go to group, I'm not going to get my medications or things like that. And so also like with the lessening of the restrictions, you know, for like, if you're providing, you know, you just have to have a place to refer. And so we refer to additional support, whether that's in-house or out. If somebody's just really struggling, we'll refer them first to inpatient. And it's not, you know, my definition of what they're struggling, it's their definition of struggle, so that they can meet their goals. And so I think a lot of it has to do with just kind of like the structurizing of MAT. But you said you're a medical doctor, right?
No, I'm not a medical doctor.
Oh, okay. So maybe, you know, and maybe if your treatment center had an in-house waivered provider, that would also, you know, like that could be a great linkage. You know, if that was an in-house service that you guys offered for patients, so that like they could just check in and get their meds there, and that would be like another option for places. And it would show that, because I know when one of our treatment centers a couple years ago wasn't doing bupe treatment, methadone's really hard to get anywhere in Alaska, but bupe treatment, the minute that they open the door for long-acting injectables and stuff, I can get people, I mean, like, that is a hot spot right now for people to get in and get stabilized and all that stuff. But the other thing too, I'd be curious, does IHS have behavioral health aides at
No.
that hospital?
No. They have asked me for job descriptions for peer specialists because they're looking at hiring behavioral health peer specialists. And yeah, I'm planning on doing strategic planning that will include Indian Health Services coming together with our 638 outpatient treatment services here so that we can work on this more closely, building that relationship, because like you said, was there a relationship? It doesn't appear that way to me. I'm new here. I've been here for about a year, and like I said, I'm taking over the TOR grant that sort of, it went dormant here, and the tribe still had the funds. So I'm like, we need to pick this back up and get it up and running because there's a lot to be gained by the community here.
Well, I hope you'll continue participating in our parent share things, because you can learn a lot in those sessions from other grantees.
Yeah, today's meeting has really been good.
I'm glad. Are there any other questions or topics that anyone would like to bring up today?
I think we lost Avis. I shouldn't have been giving her a hard time about her bad mic.
It's all your fault, Steve. Well, I want to, if there aren't any other topics that people would like to discuss, I want to thank you all for making the time to be here today. I think we shared some very valuable information, different resources and ideas. And thank you, Brittany, for also making the time to be here today. Appreciate it. In the chat, I have put the link to our Article survey. Even though it's a relatively small sample size, we still would like you to take a few moments to provide your feedback. And it has been our great pleasure to work with the TOR grantees. I can't even begin to describe how much we've learned from you all over the last 4 years, right, Steve? Oh, thank you, Emily. Another great resource in the chat from Annette from the Tribal Health Consortium, correct? Doug, are you there? Brittany is asking if she doesn't have a call scheduled with you, please reach out to her to get one scheduled. Doug, you're back.
Yeah, you want me to do a closing blessing?
If you are willing to, since you kind of got cheated out of doing an opening.
Okay.
But if you would send us off in a good way, that would be wonderful.
All right. Well, thanks everybody for coming. We appreciate all the information that you've shared. We just want to ask our blessing on this meeting. It's a it's important work that we're doing, and we're glad that we're all doing it, and I'm glad that we're able to support each other, and just ask that the Creator blesses us within our work. And thanks everybody for attending.
Thank you, Doug. Thank you, everyone. Have a great rest of your day.